Thank you very much, Dr. Subramanian, for being with us here again. We've already covered the respiratory station of Station 1 already, so do check that out, and the link should be here somewhere. And in that station we covered a lot of the basics on how to present. But today we'll be covering the abdominal station. So I was just wondering, Dr. Subramanian, if you could cover originally some of the common cases that you get in an abdominal station.
Once again, remember, you're not going to get somebody who is acutely ill.
Mm-hmm.
So people like acute pancreatitis, really severe hepatic encephalopathies and stuff, they're not going to be there. They're all stable patients.
Mm-hmm.
There are a few which are very commonly seen because they are quite stable patients.
Mm-hmm.
So you see people with kidney failure, with or without a transplant. So if you see a renal failure, it's either due to primary renal pathology, like glomerulonephritis, or they've got something like polycystic kidney disease.
Mm-hmm.
Those are the two common things you would see in the exam. So glomerulonephritis, polycystic kidney, whichever it is, if they've got end-stage renal failure, they're going to have renal replacement therapy, either in the form of dialysis, one or the other type of dialysis, or a renal transplant. The second group of people you'll get is chronic liver disease.
Mm-hmm.
They may or may not have features of hepatomegaly or splenomegaly, but they certainly will have features of chronic liver disease like spider nevi, plus minus jaundice, etc.
Mm-hmm.
The third group is you might see somebody who had had pancreatitis
Mm-hmm.
for ulcerative colitis. It becomes very evident because they usually have a very long scar.
Mm-hmm.
The fourth is you might have isolated splenomegaly. So people like spherocytosis.
Mm-hmm.
Obviously you're not going to get chronic malaria in this country. If you're doing this elsewhere, in parts of the world where chronic malaria is endemic, you might see that, of course.
Mm-hmm.
So it's either hereditary spherocytosis when it is a small spleen, or it's a lymphoid myeloproliferative disorder when you get a larger spleen,
Mm-hmm.
plus minus liver.
Mm-hmm.
And the last but not the least is you might have a liver transplant
Mm-hmm.
with a Mercedes sign scar.
Just to clarify, for the format of each of the examination stations in stations 1 and stations 3, we have I was wondering if you could just quickly tell us the time format.
When the bell rings, you come into the room. Most people would have cleaned their hands with alcohol gel, which will be outside.
Mm-hmm.
If not, that'll be inside as well, but make sure you do that. You get 6 minutes to examine the patient. You can finish in 2 minutes, 3 minutes, it doesn't matter. You get a maximum of 6 minutes. At the end of 5 minutes, we'll give you a warning saying you've got 1 minute left. So if you've got lots of stuff to do, you may want to prioritize at that stage. At 6 minutes, irrespective of whether you've finished your examination or not, we'll stop you. We'll say, leave now. If you don't leave and continue to examine, then that will go against you. So if we tell you to stop examining, stop. It may be that you haven't got all the findings, but at the end of the day, you will fail anyway if you don't get the diagnosis or you continue to examine despite our advice. So 6 minutes will stop you, and we'll have 4 minutes to question you after that in stations 1 and 3.
Thank you very much for that kind of overview of the common cases. I just wondered, what would you say are your most important tips and or common pitfalls for this particular, the abdominal part?
The first thing is please ensure that the patient is not in any pain, because a lot of these conditions can be painful. If you have a renal transplant, generally speaking, you don't get people who are rejecting the transplant in the exam because they are quite unwell. But even so, just ensure that they don't have any pain. And people with chronic liver disease, if they've got hepatomegaly, that can be painful. Polycystic kidney disease can be painful. So it's quite important to make sure that they don't have any pain.
And is that just a matter of acknowledging it, and proceeding carefully if they do have pain, or is it a case of if they do have pain, just avoiding that particular part of it?
It depends on what the patient says. If you ask them, have you got any pain? Then the patient might say, yes, I've got a bit of pain in the right quadrant or wherever. You can ask the patient, would it be okay if I examine you? And if they say, yes, please go ahead, then also make sure you tell them, if that hurts you at any point in time, when you think it's not appropriate for me to carry on, please tell me and I will stop.
Great.
So then as an examiner, I know you have taken adequate precautions before you proceeded. There are times, if the pain is quite significant, then I might tell you as an examiner, please avoid doing that and do the rest. It might be any of the systems, for example. So if I don't want you to examine something for a specific reason, I will tell you so, in which case avoid it. Don't go. I've seen numerous candidates who completely ignore what I tell them and carry on examining. And then that becomes an issue with patient welfare. So it's quite important to listen to the examiner. Usually they will tell you whether you can proceed with examination or not. And sometimes the other way around as well is, the patient might say, yes, I've got some pain, but if it is a significant finding, the examiner will say, please carry on, I will tell you if you need to stop.
Great. So one question that we often have regarding examinations, and in particular for the abdo station this time, is regarding exposure. How much exposure is needed for the abdominal examination?
Most of the time we say expose or look at the patient to start with. The problem with the abdominal system is with smaller scars or very subtle scars, you won't see it from a distance. So the slight difference is I would check the pulse and anemia and stuff like that to start with, which takes you probably about 10-15 seconds max, and then expose at that stage. How much to expose? I guess it depends on a man or a woman. If it is a man, usually they tend to have hospital gowns, so they can expose straight away. It is quite important to look at the upper part of the chest because spider nevi tends to be more prominent there. If they have a vest on, you can ask them to take the vest off, unless it's really cold and they're not keen on doing that. Usually that shouldn't be a problem. They can take the vest off. If it is a woman, in general for an abdominal examination, I wouldn't take the bra off unless the examiner tells you to do so. So quickly look at the patient, see if they're comfortable and stuff when you walk into the room. Check the pulse, anemia, polycythemia kind of stuff, obviously after seeking permission. And once you've done that, as you're going to start doing the abdominal system itself, expose them completely at that stage. Don't expose the groins, as I mentioned. It's a matter of just telling the examiner at the end of it, saying, would you like me to examine the external genitals? Or something like, I would complete my examination by examining the external genitals as well. But it is quite important to expose as low as possible because you can otherwise very easily miss a renal transplant scar in the groin.
Great. So if someone has a renal transplant, what are the specific things to look for / mention?
With a renal transplant, there are a few things you need to mention. First of all, you need to say where the transplant is, because typically they put it in the right groin, in the right inguinal area, because that's where it's easiest to connect the vasculature and the ureter and stuff. If you see the transplant on the left side, beware, because, or any other area, beware of it, because the question is that a second or a third transplant? There are occasionally times when the first gets rejected and they end up getting the second transplant. The transplanted kidney may have been removed before, but because you've already operated on twice in that area, it becomes really difficult to put the transplanted kidney there. So it's important to say where it is. Secondly, you need to know what has happened to the native kidney. So looking for scars in the back for nephrectomy will tell you has the native kidney been removed or not. And bilaterally, it might be bilateral or it might be unilateral, just look for it. The third thing is you're looking for the kidney, whether it is rejected or is there any evidence of rejection. That would be about tenderness over the transplanted kidney. If the transplanted kidney is tender, then there is some evidence of rejection clinically. The last but not least is, if that has been rejected, and if it is not giving a problem, they might still leave it there. There's no point operating on it when you don't need to do surgery. in which case they might revert back to dialysis. So you're looking for, is there any evidence of PD catheter, which suggests they are on PD, or is there AV fistula? Generally speaking, an AV fistula is done way before they start the dialysis, because you don't want to do the procedure emergency. You want to do it as an elective procedure. It's much less risk associated with that. So if you get it through, that means the fistula is functioning, i.e. there is communication between the artery and the vein. The next question is, do they have is the fistula being used? If the fistula is being used, they will have needle stick marks in the fistula region. So it's worth talking about all those. So where is the transplanted kidney? What's happened to the native kidney? Is there any evidence of dialysis at the moment? And last but not least, if you're on transplant, if you've got a renal transplant, you're going to be on some immunosuppressant therapy. So there are features which might suggest they might be tremulous from tacrolimus, or in the old-fashioned, if they're on cyclosporin or azacitidine, you're going to have gum hypertrophy. Any steroid used might give rise to Cushing's kind of features. So they're all quite important to mention if they've got a transplant.
Thank you so much. So now, in terms of presentation of examination, could you give us an example of a not so great presentation?
So let's go back to the example of a renal transplant.
Mm-hmm.
So you've examined the patient, and then I ask you, so what do you think is going on? The candidate might say, I think this patient has got end-stage renal failure, has got a transplant in the right iliac fossa, renal transplant in the right iliac fossa, which I think is functioning, and stop at that. That looks, at the outset, it looks reasonable, because they've identified end-stage renal failure, they've identified the patient has got a transplant, and the transplant is functional. Whereas the alternative would be, I think this patient has got end-stage renal failure and has had a transplanted kidney in the right iliac fossa. There's no evidence of tenderness to suggest clinical features of rejection. I haven't seen any marks on the fistula. The fistula is functioning, but it hasn't been recently used. And I note there are no scars in the back of the in the renal angle, suggesting the patient probably hasn't had nephrectomy. It suggests it's more a primary renal disease rather than polycystic kidney disease or a renal malignancies. That encompasses everything you need to know about that patient. And you could add on, if you want, to say, I haven't seen any features of immunosuppressive therapy, but I'm sure the patient is on something like tacrolimus, which is a commonly used drug.
And how would you extend that to a liver or a pancolectomy patient?
So, liver is probably more common. Pancolectomy is extremely rare to get.
Mm.
So a liver is, I think this patient has got, or you could even say, if you're reasonably certain, this patient has got chronic liver disease, as evidenced by 3 centimeter hepatomegaly below the right costal margin. There are features of spider nevi. The patient has got edema, suggesting the patient has got secondary hyperaldosteronism. There is evidence of ascites, suggesting portal hypertension. So you could say that and then say, I would like to, and proceed further from there.
Mm.
When you're talking about management itself, I think investigation is quite important, because once you've said that, you may carry on. You don't need to wait for me to ask you the question.
Mm.
So taking the example of the chronic liver disease, I would proceed and say, this is what I've found. Now I would like to do further investigations. I would like to do, even though I suspect clinically it's a cirrhotic liver disease, I would like to do a fibroscan to confirm how much fibrosis has taken place in the liver. I would like to assess the liver's function, not only with transaminases, but I want to know how it is in terms of the production ability, like clotting factors and albumin. I would like to, if there is any suspicion when you examine, you're thinking the patient is unwell or something, I would like to tap the ascitic fluid and look for SPP, because sometimes it's spontaneous and it can be quite subtle in some instances. I think that would be generally sufficient. Then you go on to the management at that stage, because unless I have something else to ask you, I would just let you carry on. Because the more you say to me, the more chance I have of marking you as satisfactory. The less you've got to tell me, I don't have that ability to do that. So proceed on from there.
And in terms of management, is there anything in particular?
So again, going back to the liver disease, it's about how you prevent hepatic encephalopathy, how you prevent, if at all, progression of liver dysfunction, like stopping alcohol or drugs or whatever it is. And by the way, I think it's quite important when you're giving a differential, you would be asked a differential. Why do you think the patient has got chronic liver disease? Or why do you think the patient has had renal failure? Don't go to the bizarre, go to the common stuff. And common stuff for liver dysfunction is either alcoholic liver disease or non-alcoholic liver disease. If you see somebody who's obese, then it's more likely NASH rather than NASH. It is expected that in the future NASH will be more common than NASH. So say the common things rather than some random bizarre stuff. And then you can go on to drugs and stuff. How often you see drug-related chronic liver disease? You don't. You'd see acute liver disease, but not chronic. So it's about thinking what you're going to answer for that particular individual. You don't want to regurgitate what you've read in the books, all 100 causes of liver dysfunction. Saying somebody who's about 70 and say has got no other features, say, oh, it could be Wilson's or hemochromatosis, it's rubbish. It's probably ASH or NASH. They are the common ones. Similarly, when it comes to kidney failure, for example, you need to say, well, it is, if they've got features of palatable kidney, then they've got polycystic kidney disease. Otherwise, it's commonly primary glomerulonephritis. It could be any of those in histology, but you can't work that out clinically. So it's quite important to remember that. Occasionally drugs might do that, but you can add that on as a latter one rather than as an initial one. You may want to have a differential at that stage. When it comes to splenomegaly, for example, or hepatosplenomegaly, then you think about lymphoid myeloproliferative disease. You're not going to get AML, for example. They're going to be desperately ill. So it's usually CLL, myelofibrosis, possibly CML. So if you say it's either lymphoid myeloproliferative disorder, and I would like to investigate according to that, for example, bone marrow and blood film, looking for hemolysis, anemia, all kinds of stuff, that would be quite helpful. And again, remember, we are looking for principles of management. I don't want you to tell me exactly what it involves in managing a patient with hepatic encephalopathy. I want to know you would give lactulose to make sure they're not going to get constipated and develop hepatic encephalopathy. I want to know if they have clotting dysfunction, how are you going to manage that? It's about making sure that that abdominal clotting is corrected. I want to know that you will advise them for certain stop alcohol if they're alcoholic. If they have NASH, I would like you to tell them to lose weight. So we're looking for basic principles of management rather than the details of management. It might sound odd I say this, but when we discuss about the neurology, you will understand the rationale why I say this, because when I'm talking about Parkinson's, I don't want to know the drug dose. I want to know the principles of management. So the same thing applies.
Thank you so much, Dr. Subramanian, for this excellent talk on the abdominal station.
It's a pleasure.